Let me now introduce our final speaker for the webinar today, which is Professor Azra Ghani. Azra is Professor and Chair in Infectious Disease Epidemiology at Imperial College in London. Her research combines the use of mathematical models and statistical methods to understand the transmission dynamics and control of a range of infectious diseases of humans and animals. She's a world leader in malaria modeling and works to develop models that can inform policies on how, where, and when to implement different interventions against malaria to aid local elimination and eventual eradication of the parasite. She's worked on a wide range of infectious diseases, including BSE and variant CJD, sexually transmitted infections, and most recently has been playing a leading and influential role in understanding the potential impact of COVID-19 in low and middle income settings. And she advises the WHO as well as other major development and public health agencies. Azra, over to you.
Great. Thank you very much, Nim, for the introduction, and thank you, Gabriel, and also Neil for the previous talks. So I'm going to focus today really on thinking about the COVID pandemic in terms of a global perspective and what's happening globally and what different countries can learn from what's happened so far to inform the response going forwards. So as we're all aware, back in March, really the pandemic took off at a global scale, moving first from Southeast Asia and notably China through to Europe, which was the first region really badly hit. And at that time, many countries implemented strategies to try to suppress transmission. And as I'll show you later, there were differences by region and by income group in terms of the responses that were made, but most were doing so earlier in their epidemic than the higher income countries. And so they more effectively prevented early exponential growth. And that may partly just be due to luck of where the pandemic first took off, observing what was happening in other countries and therefore putting interventions in place. But as we've seen since that time, and as epidemics have continued to challenge the globe, both from a public health perspective, but also more importantly economically, suppression is a very difficult strategy to sustain because of the impact that it has on people's livelihoods. So now what we're seeing is really a relaxing of most of these interventions and much more of a focus on case testing, contact tracing, and trying to get on top of local epidemics. But we're also seeing continued epidemics in many regions of the world. Most recently, Europe is now starting to experience what might be termed a second wave or recurrent epidemics. North America has been struggling. Latin America has clearly experienced some very severe epidemics across most countries, the Middle East also, and South Asia in particular, India and Pakistan. And the interesting question, and I think it's already been posed by one of our audience members, is that Africa appears to be less affected to date, although there are some notable exceptions, and you'll hear directly from Dr. Salal tomorrow about the South Africa experience. So you can see this shifting pandemic in the figure here. This really, the early epidemic here in March, April, really represents what was happening in Europe, and then the US taking off later. But then really the infection is now established across the globe, and we're starting to see the pandemic and case reporting equally spread across many countries, but interestingly, of course, not in the lowest income sector. So what we have is essentially what we think is the same pathogen. Of course, there could be mutations happening, but probably not significant at this time, but very different contexts from an epidemiological perspective that are driving transmission. So some of our earliest work was to try to get a sense of what will this infection look like in different settings, and what are the key factors that we think from an epidemiological perspective might influence this. And clearly, given the very strong age gradient with risk, as we've already seen from both of the previous talks, the demography is really going to be very important. We also know that males are far more likely to experience severe outcomes than females. So demographic patterns, of course, differ by country, and you tend to see the oldest populations in the highest income settings, here shown in the highest 10%. In terms of the age, and then as you move towards the lower income settings, the population as a whole is skewed towards a much younger population. And so it's been hypothesized, and it's likely borne out, that in some ways this can be a protective factor for the lower income settings, simply because those elderly populations are very small. But the second, I think, equally important thing is how people mix and how transmission is occurring. And so societal structure and contact patterns become quite important. And as you can see in the bottom here, these are data on mixing patterns that have been collected from various studies. A lot of these studies have been undertaken in high income countries, but many more recently in middle income and lower middle income settings. And what we see in the highest income settings is that the elderly are actually less in contact with the rest of the population comparatively, so are less connected, and this is partly due to the demographics of living separately, for example in care homes, but also in isolation rather than living in large intergenerational households. And this is different from many other parts of the world where there's much more contact across all generations, and really again driven probably by housing. And the third factor clearly is relevant comorbidities, and I'll go back to that in a later slide. So we tried to put all of these factors early on into a very simple SEIR framework to try and understand how these factors would combine together. And this just shows the likely impact in terms of total size of an epidemic of these different factors together. So on the left bar chart here, you can see the infection, so the attack rate distributed by age, predicted by primarily by those different mixing patterns between different settings. And you can see pretty much if you left the infection to run right through the population with absolutely no interventions, you'd expect fairly similar attack rates across the different income groups and a distribution across all different age groups. However, then when you translate that into hospitalisation or critical care, so ICU facilities, or indeed deaths per population, you start to see a very different pattern. And because of this very strong age profile, you'd start to see a very increased risk of all of the more severe outcomes in higher income countries compared to lower income countries. So combined, although there is an element of an increased risk with mixing patterns in the lower income countries, the very strong age gradient is actually acting in a protective manner, and this may be part of the reason the severe epidemics are not being observed to the same extent, although they are present in the lower income settings. However, it isn't just a factor of risk as defined in terms of outcomes and hospitalisation, but also determined by the health system and its capacity to respond and provide appropriate treatment for those who do require hospitalisation. So we often focus on the very critical end, but COVID is certainly not a mild disease, even in what are determined mild cases, and some of these outcomes can be quite severe. And one of the really most important interventions for those who move into having breathing difficulties is the availability of oxygen. And oxygen availability is really quite hard to track across the world, but is certainly not present to the same degree in lower income settings. And what's important also is not just the availability of the oxygen, but the quality, so having the available concentrators and flow rates sufficient to treat the disease. And so if we start to take some of these factors into account, and these were really just hypothetical ways of looking at what that would do to the infection fatality ratio with the lack of either mechanical ventilation, so in an ICU facility, or oxygen, or indeed just having poor outcomes because the facilities aren't there to adequately treat these types of infections, you could start to expect a shift away from all the infection fatality ratio being in the oldest age groups to potentially more of a risk of fatality in the 50 age group upwards. And that would be shifting, therefore, the risk up in these settings, given that the populations are slightly younger and those age groups are more prevalent. These are clearly factors that may determine why some countries have been less affected, and I've discussed a little bit age and demography. Comorbidities is obviously a really big driver, and we know a lot more now than we did even 3 or 4 months ago about the major comorbidities underlying risk. Things like obesity, chronic obstructive pulmonary disease, cardiovascular disease, many of the very common non-communicable diseases. And we also know from data from South Africa that I'm sure you'll hear about tomorrow, that HIV and TB also pose an increased risk of poor outcomes. And many of these factors actually are not really that much more prevalent in higher income countries, and you can see that in a publication by Andy Clark. You see a very similar distribution in terms of the age breakdown proportionally in the highest income settings and then going down into lower income settings. But what you do see is, of course, less of that population present. So when you translate that with those demography age bands on top of it, you would expect to see far more of these risk groups in Europe compared to Asia, and certainly very low risk in Africa. So these may be one of the factors driving what we're actually observing in the different places. But what I also want to go on to is, of course, that some countries will also be less affected because of interventions. And then also it may be that they're not less affected, but surveillance is also playing a role in how we are interpreting the patterns that we're observing. So just to say a little bit about interventions at a very broad scale, and this is an analysis that we undertook back in May, June, so really looking at the first initial responses. And as I mentioned at the beginning, really most countries went for a very abrupt responses in March, really driven by probably what was happening in Europe. And we can see across the different regions of the world that many countries initiated what we might term suppression measures, so fairly severe either localised lockdowns or indeed national lockdowns, or some sort of movement restrictions on things like mass gatherings, movement between regions within a country, as well as closing of international borders. And as I think generally that early response was quite similar across many parts of the world, and therefore ought to have had a very similar effect. However, what is important is the date that this happened. And for most regions, this was really happening in late March. And what this means in terms of their epidemic stage was that this was relatively late in Europe. So you'll see here that the median numbers of cases per million at that suppression time was 72 cases, compared to other regions of the world that were observing this. And you'll note, in particular in sub-Saharan Africa, suppression occurred very early on when very few cases were being reported, and similarly in Latin America. And what that means was that those countries were managing to suppress at the very early stages of the exponential growth in their respective countries and regions, and therefore had a very rapid impact and reducing the reproduction number substantially. And we saw that in terms of the very rapid reduction in cases in those regions compared to Europe, which had left much of this a fair bit later. But of course, as those suppression measures have been relaxed, we've started to see epidemics take off in the absence of other interventions. And one thing we struggle with, of course, when comparing really understanding an epidemic in any country is the surveillance system, when we have to really understand what the surveillance system is capturing in order to interpret the data. And this has been challenging across the globe. Early on, in places like the UK, there was a focus on testing just for severe cases in hospitals, and therefore the wider community spread was not always recognised. So obviously testing rates determine how much of the epidemic is being uncovered and really need to be taken into account when looking at making comparisons between countries or even understanding an epidemic within countries. But we can now look at things like case positivity rates, and this is examples shown from our World in Data, looking at the positivity rates for testing at the current time. And if case positivity rates, most of the cases you're finding are positive, that suggests that there's probably an awful lot more infection out there that you're not capturing. And really what you should be aiming for is a very low positivity rate, because that means that you are capturing not just the cases, you're looking at all the contacts, looking at all possible symptomatic infections, and you're finding a lot of them aren't there. So areas that have very high case positivity rates are probably not really capturing a large part of the epidemic, and this means that it's very challenging to interpret the low case reports from some settings. What we've tended to focus on as a slightly more robust but still problematic measure is death reporting. And when we've done that, and what I'll show in some example slides, is that death reporting tends to suggest higher levels of infection than are being reported by cases, even where the case positivity rate is reasonably low. However, it is also challenging to report, and certainly in many countries where vital registration systems are not in place, we know that we're probably also potentially massively underestimating the deaths that's occurring. And again, this might be another explanation for why we're not seeing epidemics in some parts of the world. So just to say a little bit about the framework we've developed and the approach we took quite early on, was to try and obtain a very simple SEIR modelling framework, which is shown here, which will be familiar. There's a lot of these SEIR models out there, but I think it's the way that you integrate data and think about patterns that becomes important. So there are clearly epidemiological characteristics that we've seen in the previous talks that are important to characterise early on, and a lot of the work was done very similar to the work that Gabriel presented. Looking at things like the generation time distribution, the distribution of symptom to death, the distribution of symptom to recovery, and getting some estimates early on of the basic reproduction number. So those are key parameters that really drive the transmission part of the model. And then we've also spent a lot of time focusing on age patterns of severity. So the infection fatality ratio is a key aspect, but also who ends up requiring clinical care in hospital, which subpopulations will require critical care, and what are the times spent in each of these areas. Then, to generalise this across different countries, we've also tried to capture healthcare capacity and quality, and this is very broad given the data that are available on a global scale, but trying to get estimates or make estimates of numbers of hospital beds, ICU beds, and how long people might stay in those settings. And once we have all those parameters together, what we've then developed is an inference framework where we can take this model, also try to capture changes in time over time in transmission through a very similar approach to that described by Gabriel, using Google mobility data to try and map how people's behaviour has changed. And then we fit this within an inference framework using particle MCMC to the observed number of deaths. And then once we've obtained those fits, we can go on to make short-term scenario projections of what we think might have happened, as well as to get back estimates of the reproduction number over time and the numbers of infections. And all of this is done within an open framework on GitHub. The model and all the code can be accessed here. So how are we using this information? Well, the main aim that we had was to try and provide the sorts of information that many countries might want that we can't provide necessarily through local support, particularly for countries that don't have modelling teams available locally, but also those that we're not working with or that wanted extra information. And there was actually quite a huge demand generated in March for all the modelling groups worldwide to provide these sorts of scenarios. And I think possibly it's really shown that there's fairly limited capacity despite quite a large number of groups working full-time on this. So the way we've gone about this is to use this framework to make short-term projections in what we're calling a dashboard, and I'll go to show some of that information, and that gets updated every few days automatically, drawing in information, and we publish the information for all the lower middle income countries. The work is also done for the high income countries, but we're not publishing it at the moment because the data streams and local data, and indeed modelling advice being provided in many of those countries is richer, and therefore we don't want to confuse. We've also started from around April onwards in-depth partnerships with 9 different countries, and most of these have been through existing research or public health partnerships. I'm not going to go into details of the particular analyses done there today, but they all reflect different questions being posed by the national governments and the different contexts in which transmission is occurring, and the differences between countries I think are very informative in understanding how this pathogen is being transmitted. And finally, we've also generated an interface to the model. It's a fairly user-friendly scenario analysis tool for simulations that's available here. So just to give some examples, these are all examples from Nigeria. We're also working at a state level as well as nationally. First of all, the model works essentially, it's a stochastic model, and we are fitting the model up to the current day. So these are the reports. You can see there's a lot of variation in day-to-day reporting, and actually there's some systematic variation in some countries that do make this challenging. Things like not reporting at weekends and all those infections occurring on a Monday, for example. So we are trying as best we can to capture these patterns, and then once we've got these patterns, we keep the estimate of the RT at the current time constant and project forwards, much like Gabriel was showing for his analysis for Hong Kong. So firstly, looking back in time, what that allows us to do is when we've estimated or fitted the model to the reported deaths, we can back estimate how many people we think might have been infected in time, and we can compare that. That's shown here in the blue with, of course, very wide uncertainty bounds. But then we can compare that to the reported cases, and here you see the reported cases for Nigeria, and this is just blowing up that part of the graph so you can see actually what the reported epidemic looks like. The shape is very similar, but in fact the test positivity rate in Nigeria is actually quite high, which is suggestive that there is probably more infection going on, and that is at least consistent with our interpretation of the reported deaths. But both give similar trends in suggesting that the epidemic has, for the time being, peaked and is in decline. And these shows the resulting estimates of the reproductive number over time. And the green line here is really informed partly by mobility data, as I said earlier, the Google mobility data. So we use that as a parameter to try and determine what the reproduction number is, and as Gabriel shown, these movement data generally correlate quite well. There are some countries where that correlation falls apart later on in the epidemic. So as we can see here, at the current time, our best estimate is that the reproduction number is below 1 in Nigeria. Nigeria is obviously a very large country, and what we're seeing is there's a variation at a sub-national level as well. This blue line actually just shows the effective reproduction number in the presence of immunity, but taking away the interventions, and just again illustrates the fact that we're still very early in all these epidemics, and the level of immunity that we think is built up is certainly not sufficient to have a big impact on the reproduction number. And then finally, we try to produce some forward projections or scenarios. And I think, as again Gabriel has said already, it's impossible to make any predictions of what will happen. And the very important message is that what will happen in the future depends on your actions now. So what we're trying to do is give scenarios that suggest if you stay where you are, so to maintain the status quo, nothing changes, then this is the trajectory of the epidemic that we think you might see. If interventions are relaxed and we get, for example, a 50% increase in transmission, then we might expect it to go up again. And similarly, if it is reduced by 50%, we might expect to see this decline. And these just give the types of information on a short projection timescale that are useful for local planners. So what might hospital bed demand look like, and what might ICU bed demand look like? Okay, so just to summarise, I think there's many different factors likely to contribute to the different epidemics that have been observed globally to date, and I think it is really an interesting and ongoing research question to try and understand why we're seeing different things in different places. How much of this is due to underlying epidemiology and to underlying differences in transmission or risk? And how much is it to do with the responses? And by doing this, and by doing more and more detailed comparisons between countries as well as within countries, I think we're going to learn an awful lot about how to better control the disease, and that can be applied. I think one thing we have learned is that although we try to look globally, local context is incredibly important. So understanding local patterns and then building into that appropriate local responses is going to be critical. As has already been said, we are clearly at the early stage of the pandemic. It's nowhere near over, and we're likely to see sustained transmission for many years. And then the forward focus is likely to be on how can we best mitigate this with therapeutic interventions such as treatment and the vaccine, alongside the non-pharmaceutical interventions that we've had in place. So I'd just like to acknowledge the wider team at Imperial that have contributed to this work, and also our many different partners across the globe that we're working with on specific questions in the local countries, and funding from the Wellcome Trust and the Foreign Common Foreign Commonwealth Office for Development, or no, FCDO, whatever we're now called. Okay, thank you.
Fantastic. Thank you so much, Azra, for that insight into such important work. But also, it's exciting to see the work on the dashboard and the user-friendly interface as well. I'm sure a lot of participants may find that helpful. Perhaps one question on your talk first before we proceed to the broader group discussion. But Chandri Mapako asks on the issue of social distancing for COVID-19, and specifically that where there may be some settings in which there's some degree of, if you like, natural social distancing, contrasting, for example, rural versus urban settings in sub-Saharan Africa. Could you say a bit more about how models capture those sorts of population structure?
Yes, and I think that's a very important point, and not all models, and certainly are the simpler models, don't capture that. But the more complex models, and Neil showed some simulations from individual-based simulation applied to the UK and Sweden. We have also been applying that in Nigeria. And through that, we have much better sense of the spatial distancing between populations in urban and rural areas, and that we are able to look at that better. And you see a much slower takeoff. You would expect still to see some transmission occurring, and it may be for other reasons, therefore, that it's not actually spreading completely in those populations. But there will be, of course, behavioural responses going on as well. We are seeing infection in rural areas in many countries. What we're not also have on top of that is perhaps also potentially weaker surveillance. We tend to get much better surveillance in the big urban areas. The hospitals are there, you get the death that's being recorded in the urban areas. And we know from all our other work that surveillance tends to be much weaker. So I think it's a combined factors. We are seeing the epidemics take off in major urban areas. It's spreading out into the rural areas, but we may be missing some of that as well.